Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 23. We'll be talking about the different chlamydial species, including Chlamydia trachomatis, Chlamydia psittaci, and Chlamydia pneumonia. We'll discuss the diseases they cause, how we diagnose them, what risk factors people have to get the disease, and what we do to treat them. To Falcon Physician Review's online review for the USMLE Step 1. This is Microbiology Module 23, where we'll talk about chlamydia. Chlamydia trachomatis comes in many different serotypes and is the causative agent of a lot of human disease. For example, it's the most common cause of non-gonococcal urethritis for serogroups D through K. It's also a common cause of pelvic inflammatory disease, which is a bacterial, sexually transmitted disease in the United States. It'll cause trachoma, which is a chronic keratoconjunctivitis of varying severity, which can cause blindness, usually in Africa and sub-Saharan Africa. Serogroups A, B, and C for trachoma. Chlamydia trachomatis can cause inclusion conjunctivitis, which is usually acute, self-healing, and congenital. Serotypes D through K again. It's also a common cause of urethritis, proctitis, cervicitis, and infantile pneumonia. Finally, Chlamydia trachomatis can cause lymphogranuloma venereum, which is LGV, which is papules around the inguinal area, and then regional lymphadenitis. Serogroups L, 1, 2, and 3 are responsible for this. Chlamydia are small, obligate intracellular parasites. They possess an inner and an outer membrane, but they do not have a peptidoglycan layer, and they are unable to make their own ATP, so they require us to make it for them. Transmission of chlamydia can come through sexual contact, through the birth canal, hand-to-eye contact. What happens is the chlamydia forms in the environment an elementary body. That infects cells and then turns into a reticulate body which is found intracellularly. Chlamydia is able to inhibit phagolysosome fusion. As shown in the figure, chlamydia have two main body types. There's an elementary body, which are small and dense, and you can think of these as kind of like spores. These are what enter the cell via endocytosis. Then, once it's inside the cell, it forms a reticulate body, which replicates in the cell by fission. It uses the host ATP to accomplish this. As the infection sets up and more reticulate bodies are formed, there's a depletion of nutrients and more elementary bodies are formed. Finally, multiplication ceases when there's no more nutrients. The cell lyses and releases innumerable more elementary bodies to go and infect other cells. So that's how chlamydia works. It's dependent upon us for its replication and for ATP. Clinical findings of chlamydia infections include trachoma, again serogroups A, B, and C. This is a chronic infection or repeated reinfection. You get conjunctival scarring, ulceration of the cornea, blood vessel formation, and you can lead to blindness. Inclusion conjunctivitis is much more self-limited. You can get corneal infiltrates, and you can get a mucopurulent discharge. Inclusion conjunctivitis is found in serotypes D through K. Chlamydia is an important cause of infantile pneumonia, serotypes D through K. You get wheezing and a staccato cough, but no fever. You'll also see chlamydia as a cause of urogenital infections. 80% are asymptomatic in females. You get cervicitis, urethritis, and salpingitis. In fact, it's the #1 cause of urethritis. Reiter syndrome is a unique immunologic abnormality associated with HLA-B27 positive people. In that, you get conjunctivitis, polyarthritis, and genital inflammation or urethritis. Again, there's the mnemonic of can't pee, can't see, can't climb a tree. Chlamydia also causes lymphogranuloma venereum in serogroups L, 1, 2, and 3. These are small, painless vesicular lesions that then lead to fever, headache, and myalgia, with inflammation and enlargement of the lymph nodes and genital ulcers. Lab diagnosis of chlamydia is difficult because it cannot be cultured in inert media. You have to culture it in tissue or embryonic eggs, and they use the iodine stain for the reticulate body. Fortunately, we have nucleic acid probes where we can use direct fluorescent antibodies. Treatment for chlamydia includes doxycycline or azithromycin. Also, prevention is better than cure, and safe sex is a good prevention of chlamydia. Chlamydia psittaci is our next organism, and it's a common cause of pneumonia or psittacosis. The important thing to remember about Chlamydia psittaci is that it comes from parrots. They're the typical reservoir. They transmit it to us when we inhale the chlamydia organism from their droppings. The figure shown here shows the lifespan of Chlamydia psittaci. We inhale the organisms into our lungs, then it gets to our bloodstream, goes to the liver and spleen, and we get focal areas of necrosis. From there, it can hematogenously seed the lungs, generate an inflammatory response, and start edema, necrosis, and hemorrhage. The lungs get plugged with mucus, then you get cyanosis and anoxia. It's a bad form of pneumonia. Clinical findings of Chlamydia psittaci include fever, chills, and headache, a non-productive cough, and a mild pneumonitis, but it can be complicated with convulsions, coma, and death. You can get a carditis, hepatosplenomegaly, or just splenomegaly. Lab diagnosis again relies mostly on serologic tests, such as the complement fixation test. Treatment for Chlamydia psittaci is doxycycline or erythromycin, and also to control the infection in birds. Atypical pneumonia is where the non-pulmonary symptoms predominate, such as a fever, a headache, a myalgia. It's often characterized by a non-productive but chronic cough, whereas your typical pneumonia is pulmonary-based symptoms with a chronic productive cough with mild myalgias and sputum production. Chlamydia pneumonia is the causative agent of atypical pneumonia. It's similar to that caused by Mycoplasma pneumonia, Legionella pneumophilia, and Q fever, which is Coxiella. Transmission of chlamydia pneumonia is person to person by respiratory droplets. Clinical findings include a pharyngitis, bronchitis, and a persistent cough and malaise. In severe cases, you can get a lobar pneumonia, but mostly you don't. Lab diagnosis again relies on serologic testing for PCR. It's difficult to culture chlamydia organisms. Treatment of chlamydia pneumonia includes macrolides or doxycycline, and we don't have any vaccination available. This is a table which highlights the atypical pneumonial agents and how they vary. So the three organisms involved are Mycoplasma pneumonia, Chlamydia pneumonia, and Legionella pneumophilia. You'll find that Legionella is more likely to be severe or form a lobar pneumonia. Epidemiology for Mycoplasma and Chlamydia are pretty common. You'll find them. And in Legionella, it's more epidemic with water-based systems. You'll find the original outbreak was in a Legionnaires meeting in Michigan due to contaminated air conditioning systems. Diagnosis is usually empiric for Mycoplasma and Chlamydia, but with Legionella we have a urinary antigen we can use. The treatment, fortunately for all of them, is the same. You can do a Z-Pak, ciprofloxacin, or erythromycin. Let's do a question. A 28-year-old sexually active female presents to you with fever, nausea, vomiting, and abdominal pain. On bimanual exam, she exhibits cervical motion tenderness. On specular exam, you note a red, friable cervix with mucopurulent discharge. Microscopic analysis of the sample reveals abundant PMNs, but neither intra nor extracellular bacteria. The causative agent of this woman's condition is, so we have somebody with cervicitis. They could have pelvic inflammatory disease, but right now we know at least they have cervicitis. The most common causes of cervicitis are gonococcus and chlamydia. You don't have to worry about Chlamydia psittaci. That's more of a pneumonia-based organism like we talked about. You could have syphilis. Anything can be caused by syphilis. Or Haemophilus ducreyi is going to be less likely to cause cervicitis. You think of it more of urethritis and the chancre. So when we don't have intracellular or extracellular bacteria, that rules out Neisseria gonorrhea. And so the most likely organism is Chlamydia trachomatis. You counsel the woman in the preceding question that all of the following are possible direct sequelae of her current infection except. So this is a question about what happens when people have chronic urethritis or cervicitis. As we go through the answers, we could think about it. Infertility, you would think about through scarring of the urogenital tract due to the inflammation. Also with chlamydia, you have to think about Reiter syndrome, which includes conjunctivitis, polyarthritis, and urethritis, which is choices B through D. Pneumonia is unlikely to happen through Chlamydia trachomatis. So E is the answer. Let's wrap up Module 23 for microbiology. We talked about the Chlamydia species. It seems Chlamydia trachomatis can cause just about any disease, so you should be familiar with the different serotypes, which one cause conjunctivitis and which ones cause LGV. We talked about Chlamydia psittaci, and look for people with a chronic cough and exposure to parrots or bird droppings. Finally, we talked about Chlamydia pneumonia, one of the common causes of walking pneumonia or atypical pneumonia. be familiar with how these chlamydial organisms work, with the reticulate bodies and with the elementary bodies. And also be familiar with the treatment and identification. Next up, we're going to go to the Rickettsia in Module 24.